Good afternoon. This is Dr. John Bennett from Miami Beach for Neurosurgical TV. We have the pleasure of having another presentation from the Association of Future Neurosurgeons of Africa. And we have the pleasure of having Ulrick Sidney, who's doing a fellowship at Harvard in Boston now, and he's giving us this presentation. But first, let's go around to the panel to briefly introduce them. Hello, Abdullah. Could you please introduce yourself, please? Yeah, just introduce yourself.
Great pleasure to. Hello?
Yes, we can hear you. Go ahead.
I am Abdullah Bashir from Benghazi, Libya. I'm a resident in neurosurgery, and it's a great pleasure and honor for me to share you about ICP monitoring and ICP management. Is very nice subject, and it's facing trauma here in Africa. There is many cases of trauma here in Africa, and we're dealing with these cases every day, every week, every minute. And I think management about mannitol or dexamethasone is very big difference between them. In the trauma, we use mannitol because according to the type of the edema, we're using the mannitol. According to the type of the edema, we use mannitol. And if there is a tumor or we'll give dexa.
Excuse me, Abdullah. Okay. We're just introducing you here. Okay. Okay. Let's introduce Dr. Kabulo. Hello, Dr. Kabulo. Unmute yourself.
My name is Kabulo from Democratic Republic of Congo. Currently, final year neurosurgery resident at the University of Zimbabwe.
Well, welcome, Dr. Kabulo. Zolo, who've just finished a great presentation. Hello, Zolo.
Hello, Dr. John. Hello, everybody. I am Zolo Uswandrevan. I'm a CTM medical student from the University of Buea, Cameroon. I'm happy to be here.
Okay, well, welcome to. Okay, Ulrick, thank you for presenting and thank you for organizing this, and it's all yours.
Yes, thank you, Dr. Bennett. Thanks to everyone who's here, and thank you so much to Zolo for this amazing presentation. You really did a great job talking about intracranial pressure, and we look forward to the rest of the presentation, definitely. But great job. You should be proud of yourself. So today we're going to continue with the other forms of brain monitoring. So in terms of brain monitoring, we'll be focused mainly on invasive multi-modality brain monitoring. I am Ulrick Sidney, a research associate at the program in Global Surgery and Social Change at Harvard Medical School. And this will be a presentation I will have today on multi-modality brain monitoring. So just a small recap of what we already heard from Zolo Ivan. We know that intracranial pressure, the increase of intracranial pressure is an issue, and it's even more so when the brain is unable to compensate for this increase. So refractory ICP is the primary cause of death in both stroke and traumatic brain injuries. And this is important, especially in our case, because traumatic brain injuries as well as strokes are responsible for big mortality and morbidity in the world, especially in low and middle income countries. Traumatic brain injuries account for a very sizable amount of accidental injuries, and the morbidity is very heavy and mortality is very heavy. Many reasons for this, obviously, which we could discuss later on in another presentation. Identifying patients who will benefit from ICP is based usually on the clinical and radiologic evaluations. We did a presentation last week already on certain of these clinical signs which we'll be looking out for. We're going to present another one on the radiologic signs that indicate multimodality brain imaging. So, and the primary goal of ICP monitoring is to maintain adequate cerebral perfusion. Like Zolo adequately said, we have a formula. We know that the cerebral perfusion, the CPP, is equal to the mean arterial pressure minus the intracranial pressure. So if we're able to manage a mean arterial pressure, keep it within the right range, and manage the ICP, then we can obtain adequate brain perfusion. So why perfusion? This word keeps coming, and what do we have to make of it? So there are a few things we need to remember. That a cell is delimited by a cell wall, and in the cell wall we have different elements. This limit, which is the cell wall, makes the difference between the internal and the external medium. This is very important for cells to be an entity but equal to function. So when we're talking about the cell wall, what we see, for example, are the mechanisms that permit exchange between the internal medium and the external medium. So what are the things we see crossing the cell wall? Well, we see oxygen, we see glucose. And when we speak about oxygen, glucose, we see aerobic and anaerobic respiration. Bear with me here that we go back into this cell physiology before we get into the more complex, more detailed modalities, because these modalities cost a lot of money for the institutions, for the patients as well. And you need to know what you're looking for. You need to understand what the output of these machines would be. So in terms of aerobic or anaerobic respiration, from glucose, cells produce ATP. Now, this happens through two mechanisms: a cytosolic, two steps, a cytosolic step and a mitochondrial step. And in the mitochondrial step, we have two other steps. We have one that happens within the matrix of the mitochondria and between the two membranes of the mitochondria. The one in the cytosol and the one in the mitochondria's matrix is not dependent on oxygen, but the one that happens between the two membranes is dependent on oxygen. So when oxygen is present, we have between 36 and 38 ATPs formed. When it's not present, we have about 2. And this makes a big difference. That means for one molecule of glucose, if oxygen isn't present, we only have 2. If oxygen is present, we get 36 to 38. And that's a big difference. That's a massive difference. So when oxygen isn't present, what happens is we don't get value for our money. The cell doesn't get value for its money. So the conversion is not good. So it's going to run down its glucose levels. But equally, there's an intermediary product that's produced, that's pyruvic acid or pyruvate. And when this pyruvic acid accumulates, it gives lactic acid or lactate. And now when this lactic acid accumulates, like the word says, acid, so it's going to change the pH. But we know that enzymes are very sensitive to pH. So certain enzymes will not be able to work, other ones will be activated because the pH changed. But other functions of the cell as well will be altered. So the accumulation of lactic acid will lead to a dysfunction of the cell. Why do we need ATP at the level of the cell? Now, when we get ATP, one of the most important things that needs ATP is the pumps. These pumps help the movement of electrolytes like sodium, potassium, calcium. And because they do it against the concentration gradient, they need energy. This is why they need ATP. How is this important? Because we spoke about the cell wall in the beginning. The cell wall differentiated the internal medium from the external medium. These differences are subtle in terms of chemical differences and electrical differences. We call them the electrochemical different gradient. This is how we know that outside the cell, there's more sodium. Inside the cell, there's more potassium, for example. And the fact that the exchange between sodium and potassium is uneven gives us this negative gradient in terms of the electrical gradient. And this electrical gradient is what is used by cells that are excitable, like muscles and nerves, to be able to transmit an action potential. So this is very important. So what happens if these pumps don't work? Well, they wouldn't work, for example, if there's no ATP or there's not enough ATP. And if they stop working, then they don't create that gradient. And if they don't create that gradient, then the cell is not anymore neutral. It's getting activated because there's all of a sudden an influx of certain electrolytes and an efflux of other electrolytes. So we know that usually we get sodium going out of the cell, potassium coming in. That's when the pumps work. When these pumps don't work, then the concentration gradient can be followed along the other channels, and this is how there can be a discharge of those cells. The neuron, like we said, is very special in the sense that neurons and muscles are excitable. So because they're excitable, the cell wall is very important in how they function. It's very important because, as we can see from this diagram down here, we can get a few levels. We can have a level of rest, depolarization, repolarization, hyperpolarization, and this is the resting state. So if we consider this as a cell wall, forgetting this is the synapse or whatever, if this is a cell wall, so what we expect is to see sodium moving out, potassium coming in, and this is how we maintain that electrochemical gradient. Now, if we had an influx of sodium ions here, sodium ions coming in instead of going out, we get depolarization. Potassium ions going out, we get repolarization. This is what happens when we have a change in the function of the ATP-dependent pumps. Now, at the resting state, these pumps normally function by getting sodium in, out, and potassium in. So if there's no ATP, these pumps don't function. And if these pumps don't function, sodium starts coming in because it's more outside the cell. And once it comes in, we get a depolarization of a cell that wasn't meant to depolarize. And potassium starts moving in, we get this repolarization. So we have a dysfunction of the cell. Now, the brain is vulnerable to so many injuries. When an injury causes a dysfunction of the brain or the brain cells, it's a primary injury. However, there are certain injuries to the brain that can occur due to secondary aggressors. Some of them are change, like alteration of the glycemia, be it hypoglycemia, hyperglycemia, because it's going to modify how the neurons work. Fever, for example, because it increases the metabolism of these cells. Pain as well increases metabolism of nerve cells. Change in electrolyte balance. We can have a change. We say it's changing electrolyte balance. We speak about osmolarity. So these are injuries that are happening after the primary lesion. So the primary lesion could be trauma. It could be a tumor. It could be a stroke. But after this, we have all these secondary injuries. So already we have to keep that in mind. And this keeping this in mind will help us better interpret the results of the multi-modality invasive brain monitoring. Now, when the cells are not working, we have this state of excitotoxicity. What is that? What is excitotoxicity? So we find ourselves here. Okay, we are in the nerve cell, and there's for some reason things are not working properly. Now, if things are not working properly, what we understand by this is we don't have an adequate supply of oxygen, we don't have an adequate supply of glucose. If this is not the case, like we said before, we don't have ATP. Now, instead of talking about the sodium potassium ATPase pump, for example, we're going to go now to the calcium dependent, the calcium ATP dependent pumps. Now, these calcium ATP dependent pumps are supposed to keep calcium out of the cell. So when there's ATP, it keeps calcium out of the cell. When there's no ATP, this pump doesn't work. So ATP is not there, no calcium out. Now the calcium starts flowing in. This is it. Calcium starts coming in. Now, what's the problem? Calcium is able to activate certain enzymes. Calcium can activate certain enzymes, and among them we have autolytic enzymes. So we have enzymes that are able to digest the cell wall here, and the cell membrane, sorry, which are like phospholipases. We have caspases, for example, that can be activated. it can equally activate autolytic enzyme as well as producing ROS, oxygen species, radical oxygen species. That can be superoxide, anion, that can be the peroxide. Now, this peroxide, this radical oxygen species will attack the cell membrane and cause lipid peroxidation. And remember that whenever a cell loses its cell membrane, the integrity of the cell membrane, then it's basically dead. Now, this digestion can occur without leaving anything else outside, but it can equally occur and leave debris. Some of the things that can be liberated are in certain vesicles in neurons. You can find neurotransmitters. One of those neurotransmitters is glutamate. Glutamate is normally an excitatory neurotransmitter. So if you liberate glutamate outside of the cell, then it finds itself in the synaptic space. Glutamate has a few receptors, NMDA and AMPA. So if the NMDA receptor is calcium sensitive and you have glutamate, then it activates this receptor, and now there's an influx of calcium, and this brings about the same cycle we spoke before, another cell. So imagine one cell having this problem, then it transmits, it's going to happen to the next neighboring cells, and so on and so forth. So we have this cascade that keeps going on, and more neurons will be destroyed. But this destruction is not due to the primary injury. So the primary injury might have destroyed the very first cell, but it didn't destroy the other cells. So our work, our job as intensivists, or during that critical time, is to limit as much as possible the destruction of neighboring cells to stop this terrible cascade. So how do we do this? We said in the beginning, this all happened because there was a problem in oxygen supply, in glucose supply. How can this happen? It can happen because, one, there's not enough oxygen or glucose, or two, the cell requires much more oxygen, much more glucose than it usually requires, or three, a combination of both. So if you're thinking about a stroke, be it ischemic or hemorrhagic, whatever it is, if it's a stroke, there's a problem in blood supply. So there's not enough oxygen, there's not enough glucose. That's one example. Imagine a patient having seizures, status epilepticus. By having seizures, then they have a hyperactivity at the level of neurons. And so they would need a lot more oxygen, a lot more glucose than they would need normally. So that would be the second example. But we can equally have a combination of both. So when we have such patients, we need to be able to understand what's happening. Do they need more oxygen than they should? Do they need more glucose than they should? Do they not have enough oxygen? Do they not have enough glucose? So these are the questions we will be asking ourselves. Okay. This is what a neurointensive ICU, a neuro ICU will look like today. So today you'd have your patient and he'd be hooked up to all these different equipment. And we're going to speak briefly about almost all of them. So we can start with, we're going to speak about EEG, different modalities of EEG. The ventilator, remember your ABCs. ICP, Zolo already spoke about this, so it will be really quick and resumed. The IV pump, not in the monitoring, but very important. Feeding pump and tube, not in the monitoring. The Lycox, we're going to talk about this, the Hemidex, and what else? The pulse oximeter and central line. So why would you need multimodality brain monitoring? So you've received a patient, you know what the patient has in quotes. That is, your patient, you did a Glasgow Coma Scale and the patient has a 7, a 6. So your Glasgow Coma Scale tells you that your patient is in a coma. But does it tell you why the patient is in a coma? The Glasgow doesn't tell you that. Does it tell you how the patient found himself in a coma. It doesn't tell you that. So you need means to be able to get this information, because like we said last week, the history might not always be that clear, or the patient is in a coma, is not going to tell you anything. So there's difficulties there. And even if you knew the Glasgow coma scale was low because the patient had a stroke, that's not enough. You need to know, like we said, is this patient having enough oxygen, enough glucose at the level of the brain? So what can we do? We can use an ICP. Zolo spoke very well about this. Now, just a few things I'm going to add about is these different ways we can measure ICP. We're going to talk about EEGs and what they entail, and perfusion, as well as measuring the partial pressure of oxygen in the jugular vein, and using microcatheter, microdialysis. So when we do our multimodality monitoring, it's important to remember that not all patients need all forms of invasive brain multimodality monitoring. Not all patients. So the first thing you need to be able to do is to determine which patient needs which device and what will be your targets. So in this table, we have EEG. So we're going to speak about different forms of EEG later on, but here, obviously we know it's for electrical brain activity. And what we're looking out for is the alpha delta ratio. And why is it important? Well, we all need to keep in mind that when we speak about seizure and epilepsy, we really need to make the difference, right? See, the seizure, a seizure is that motor manifestation, right, of the discharge, of the abnormal discharge of our neurons, which are hyperexcitable. And now, if that is one of the manifestations of this discharge, we need to remember that that's not the only way. It can be a sensory manifestation. It can be an autonomic manifestation. It can equally be motor, like we say, in the forms of seizures. But what we need to keep in mind is this discharge does not always manifest in a motor. It doesn't have a motor manifestation. So you'd want to know if your patient is going through these ictal discharges, but not having motor manifestations. So the only way you could do that is to have, for example, an EEG. Now, the perfusion monitor, we want to get an idea of cerebral blood flow. That is, how much volume, how much blood volume do we get per 100 grams of brain parenchyma? And this gives us an idea about how much of metabolic supply of oxygen do we get. So very good. If another thing we can equally use is the jugular venous oximetry. Now, because it's venous, you can sort of get a few interpretations. You tell yourself, well, if the venous blood is very oxygenated, that must mean that the brain cells didn't use the oxygen, right? And if it's very oxygenated, then there's a problem, either in the way they use this or in the way it got to them. Another thing you can also interpret is if it uses way too much oxygen, more than it should, then you can think, hey, maybe these cells are having an increased metabolism. So what can explain this increased metabolism? We can equally measure the partial pressure of oxygen in brain parenchyma. And this gives us an idea about hypoxia, ischemia. Cerebral microdialysis helps us measure the local concentration in glucose, lactate pyruvate ratio. Remember, this block here, we spoke about it. We spoke about aerobic and anaerobic respiration. So, as a reminder, when glucose goes through the circulation, when it gets to a cell, there are glucose transporters which are expressed at the level of cell membranes. These glucose transporters enable the influx of glucose. Glucose comes in with water. Now, for glucose not to go out, it is phosphorylated. And then at the level of the cytosol, the cytoplasm, this glucose starts getting broken down. And then there's formation, a net formation of production of 2 ATPs. If things are okay, that is, if there's oxygen, then the pyruvic acid will go down the road of the citric acid cycle and go all the way to the electron transport chain, giving us a net production of 36 ATP. If there's no oxygen, the pyruvic acid accumulates and converts into lactate. Let's stop there for a minute. So what do we understand? Now, if we are going to talk about the lactate to pyruvate ratio, if we say having pyruvic acid would favor aerobic respiration, and that lactate would favor anaerobic respiration. Lactate now being the denominator, the numerator. That means if there's a lot of lactic acid or lactate, and therefore the figure is a whole number greater than 0, and so much greater than 0, then we're talking about an anaerobic state. So for some reason, there's not enough oxygen available for the cell. And if this ratio is below, then we infer that there's more pyruvic acid. So there's enough oxygen. We're going to talk about this. Now, this glutamate, we spoke about it, if you remember, in excitotoxicity. We spoke about how the very first cell is injured. It will liberate its contents into the interstitial space where there's synaptic cleft as well. And in these, we can have, for example, glutamate. Glutamate has 2 receptors, AMPA and MDA. And when it links to the calcium NMDA channels, then calcium gets into these surrounding cells, neurons. And when calcium gets into these cells, it will enable the activation of autolytic enzymes like phospholipases, for example, or caspases, for example. And this will lead to the activation of self-destruction or apoptosis. And this is how cells that were not, neurons that were not initially injured by the primary cause would find themselves dying. So glutamate gives us an idea about excitotoxicity. So glycerol equally gives us about an approximate idea about how much glutamate has been released. So ICP. We have a very complex situation, and Zolo did a very good job showing us a map of like elastance of the brain, as well as a map of the autoregulation, the vasomotor autoregulation at the level of the brain. So we saw there was a sweet spot between 50 and 150 millimeters of mercury when the brain is able to regulate. So if it feels like it needs more blood, it's going to cause vasodilation. If it feels dilatation, if it feels like it needs less blood, then it causes vasoconstriction. Because when the brain cells need more blood, they're going to have or more oxygen. They're going to liberate CO2, and this partial pressure in CO2, PaCO2, is going to lead to vasodilatation. And when it needs less, then it's going to be vasoconstriction. Now, if we are above the 150 millimeter mercury mark, what happens is we lose that mechanism. So once again, using what Zolo said, if you're respecting the Monroe-Kelly doctrine, if for one reason, one element within the skull occupies space or more space than it should, the normal thing would be for the other compartments to compensate. Now, we know the brain is not going to compensate by reducing its size. So who compensates? It's the CSF, and it can be the vascular side. And in the vessels, we all remember that the veins carry a lot more than the arteries. So the veins will start losing some of that capacitance of how much they carry. But equally, the arteries, what they do normally is they try to adapt. Now, if they're trying to adapt and they have, for example, a vasoconstriction, trying to lose not get as much blood as they should, there's going to be a moment when this doesn't work. The brain cells will be like, we need oxygen, we need glucose. So they produce CO2. The PaCO2 goes up. If the PaCO2 goes up, well, it creates vasodilatation. So now the vascular compartment is increasing as well. So this is a reflex which is not good for the contents in the brain. So now you have the increase in blood in intracranial pressure, because not only there's this cause that was occupying space, but now the vessels are not able to modify the diameters, and they're all vasodilated. So you have an increase in ICP. Now this increase in ICP will prompt an external action, and the external action should have the consequence of reducing ICP. So how do we come up about interpreting these changes and understanding these changes? Zolo explained that there were quite a few methods to be able to monitor ICP. Some were non-invasive, others were invasive. Now, most of the methods give you a snapshot. They don't give you a reading of the ICP as time goes on. So if you take a transcranial Doppler, if you take an ultrasound of the optic nerve sheath, what you get as value is the value at that moment you're doing the examination. So you don't have a continuous reading. So if things change, there's a problem. So what did we come up with? We came up with this invasive intracranial pressure monitoring. Now, this can be at different levels. It can be subdural, right? It can be at the level of the ventricle. It can be at the level of the parenchyma. Each of them have their advantages and their disadvantages. So as you'd guess, the more superficial ones will be easier to place, and as you'd guess, they won't be very accurate. The deeper ones would have a more accurate value, but you have more risk like hemorrhage, infections, but you have greater value. So you need to be able to strike a balance, and we've generally been able to strike a balance. But there's another advantage for the one that's intraventricular. The other advantage is with the one that's intraventricular, while you're measuring the ICP, you can equally drain some CSF. So you don't only diagnose, but you're equally able to come up with a treatment. So these are a few things that are out there. Now you get the value. You need to be able to interpret. You have to interpret according to the age. So we'll just think about the young adult and intracranial pressure. So we're thinking, well, above 15, that's not good. Above 20, that's very bad. And more than that, that's just not acceptable. So what do we want to do? We want to be able to record this and be able to interpret and act upon it. Once again, Zolo spoke about this. Mr. Lundberg described a few waves, A waves and B waves. Here, I just have the summary of what you should remember about distinguishing between A waves and B waves. So A waves, from 20 to 100 millimeters of mercury, they last a lot longer, 5 minutes. They are irregular. They are plateau shaped, and they are triggered by hypotension. However, B waves are just the opposite. They're less than 20 millimeters of mercury. They are regular. These are irregular. They are regular, and they go every 1/3 of a minute. That's 20 seconds, or every 3 minutes. And they are sinusoidal in shape. They're not plateau. So here is a continuous monitoring of intracranial pressure, ICP. This is the cerebral perfusion. This is the mean arterial pressure. Let's remember that we said CPP is equal to MAP minus ICP. And you can sort of get an idea about this, because if you look at ICP and CPP, because MAP is just about constant, it's not that variable. You'd see that everywhere you find a peak in ICP, you find, well, a crest in CPP, right? A peak, a crest. So that's what you're basically saying. That's it. Sort of a mirror image. Not perfect, but it's there. So what do we notice here? From this moment at 1 a.m. Here, 1 a.m. What happened? When we look at the ICP, well, ICP is not varying that much. It's starting to sort of plateau. And it's done this from 1 a.m. to 4 a.m. Already this is a problem because this is unacceptable. Something should have been done, but it's more than the definition is already more than 5 minutes, definitely. And it's plateauing. So there's a problem there. So ask yourself, is this an A wave or a B wave? Very simple. Values 20 to 100, lasts more than 5 minutes, irregular, plateau shape. Let's see, and triggered by hypotension. So look at the mean arterial pressure here, below 75 millimeters of mercury. So hypotension, good, you check that. You look at the values here. Oh, we said it's above 20. Is it above 20? Yes. We said it lasts more than 5 minutes. Did it last more than 5 minutes? Yes. So this is an A wave. Yeah, bang. So what else do we have? We have the cerebral perfusion pressure. So CPP, like we said, remember, CPP equals to your MAP minus your ICP. So there are a few methods that permit measurement of this cerebral perfusion pressure. Obviously, they're invasive, and like we'll find later on, one of the problems here is what you need to remember is with invasive multimodality brain monitoring, you want to be as close to the site of lesion as possible, because when you're intraparenchymal, you're just getting an idea of the environment of the probe, not the whole brain, just around that probe. So if something else is happening at a distance or more in depth, then you wouldn't be able to get that idea. So this is interesting because if the perfusion is good, then you get blood, then you get oxygen, then you get glucose. So this is interesting. Partial pressure of oxygen in brain parenchyma. This gives you an idea about, well, the movement of oxygen and in the brain parenchyma, how much of oxygen does it get? Cerebral blood flow. There are a few ways you can learn it. You can appreciate it. The non-invasive ones would be the different MRI sequences during which you can appreciate how much blood goes to the brain, how much it's used. So they're indirect measures, but to give you an idea. However, you can have more direct invasive methods. Now, intracranial EEG. So we all know the surface EEGs. So the surface EEGs, just like surface EKGs, pick up a lot of noise. They pick up quite a few things, and that's logical because they're not in direct contact with the surfaces they're trying to measure. So there's so much tissue between the surfaces they're trying to measure the electricity from and the different probes. So one way to get more accurate information is to do intracranial EEG. And like we said before, we want to get non-convulsive seizures, those ones that don't manifest by motor, don't have motor manifestations. So these are the ones, like we said, that can be autonomous, for example, that can be sensory, for example. And we equally want to know about status epilepticus, but that one that's not detected clinically. So the convulsive, and my bad, I first of all described the seizures without talking about convulsion. So we were talking about convulsion before, like the motor manifestations of these seizures, that's the convulsion. So the non-convulsive status epilepticus, these are the ones you would need EEG. And you get more sensitivity if you get intracranial, not just surface. So before coming to Fourier transformation, we can equally have use continuous video EEGs, but for this to be sensitive, you need at least 48 hours. So when does Fourier transformation come into play? So waves can be described in terms of the frequency or in terms of the duration time. And these are inversely proportional. The fact that you can move from frequency to time and time to frequency is what we call Fourier transformation and reverse Fourier transformation. Because these are information about the same waves. We're not changing the waves, but we're changing the way they are displayed or how we can interpret them. So using Fourier transformation gives us ease in how we are able to detect modification in EEGs, because to be able to do a good job at interpreting EEGs, you need some pretty solid training. But when we do the Fourier transformations and we're able to do that modification between frequency and time, then we get these expressions in terms of alpha delta ratio, and we're able to get someone with minimum EEG training to be able to get a diagnosis out of an EEG. So Fourier transformations are very good. Now, microdialysis, we all know dialysis. So here it's at the cellular level. So we have semi-permeable membrane on a catheter as a probe, and we are able to detect low molecular weight. That's to say glucose, lactic acid, pyruvic acid, glycerol, glutamate. And we already explained what they mean and how we should interpret them. They give us an idea about injury. So usually they're inserted about 10 millimeters into the brain parenchyma, and we would need to sample every 20 minutes to have an idea about, like, with time, how are things changing. So a few things we need to keep in mind. Intraparenchymal monitors may not monitor general conditions. They only give you an idea about the direct environment of the probe. This is very, very important. So if you have a lesion in the frontal lobe and you go and place your probe in the occipital lobe, you won't get enough information. You wouldn't even be able to actually do much. So this means the placement of probes has to be directed. Among one of the things that direct them, it has to be the lesions. Place your probes as close to the lesion as possible, as safely possible. Very important. Resuscitation always comes before multimodality brain monitoring, always. And this is why I liked the question by Doctors Kabulo and Dr. Nuru when they asked Zolo about what to do with a patient. I mean, it's all good to have and know these very complex forms of monitoring, but the basics still stand, right? Resuscitation, your ABCs, your clinical examination, these come before. And another thing you need to remember is once you place those probes in your patient, a lot of them are not MRI compatible. So what does this mean? Stabilize your patient and get imaging before you go and place those probes. Don't place the probes and then you want to get imaging and then you have to start manipulating. And some of these probes cannot be modified once they're placed. So once they're placed, that's it. You can't change much. So we've spoken about so many modalities, and as you'd imagine, this is too much information. It is. If you have a patient in an ICU, a neuro ICU, and you've been taking his ICP, his EEG, his partial pressure in brain parenchyma, partial pressure of oxygen for like the last 24 hours. Imagine having to go through that for 24 hours, looking at those things to find out where there are problems. And like we said, all these modalities give you information about different states. So these are too many informations. And unfortunately, these machines don't talk together. So the ICP doesn't relate to this other EEG, for example. So you need another device to be able to get all these outputs and integrate them. And even once you've integrated them, it's still difficult to be able to interpret all of this. So you need experience with these devices, but you equally need a team that's versed with it. Another problem, when you have your patient in a neuro ICU, you need one nurse per patient. You need one nurse per bed normally. So in a context, this is very difficult. This is very heavy in terms of not just how much the devices cost, but we have milieus in which infection are quite common. So you're talking about placing probes in the brain of the patient. So you need to take care of how you place these probes and how your patients are handled. So the neurosurgeons out there and residents, they know, even for things like drains, when you place your drain, having to move your patient from the OR to the bed in the ICU, for example, or to the ward is an issue. So I think everyone has had at least one case of a shunt being pulled out or seen it. So that's a big problem. So imagine having this patient and you need to be able to they still need to be cleaned. Their bed sheets still need to be changed. So you need to work with a team that's used to that. So it's very demanding, very labor intensive. These machines that help us integrate all these informations, well, we need to move forward because this is too much data. This falls in the realm of big data. What do we do with all these informations that we're collecting? And we have to ask ourselves these questions. Is there a possibility of machine learning to teach machines how to detect changes in these different results and be able to alert the team to say, oh, I detected this? Because like we said, monitoring a patient for 24 hours, 48, 72 hours, and having all this data, this is too much right now. So if you're not very experienced, this can be overwhelming. Now, cerebral autoregulatory control can be assessed. We spoke about this cerebral autoregulatory control between the 50 and 150 millimeters of mercury. So you can assess it with the parenchymal partial pressure in oxygen, the cerebral blood flow, and the CPP. And that was it. Thanks.
Unmuted here. Yeah, thank you very. I'm sorry. Thank you very much, Ulrick. A great presentation, and thanks for putting all this together. And Abdullah, I see you hung in there. Any questions or comments for Ulrick? Abdullah? Let me unmute you there. Okay. Or, okay, I can't. Okay, Zolo, any comments or questions? Let me unmute you. There you go.
Hello.
Yeah.
Yes, hello. I have no question. The only comment is that it was a very nice presentation, brilliant presentation, detailed presentation. I like it showed all the presentation was so very about the physiology lecture that was really impressive and gave me to see to have better insight into neurophysiology. So thank you very much, Dr. Sidney, for the presentation.
Okay.
That were given is true. I read on it, but the format used and the how it was being placed was really impressive. Thank you very much for the presentation. Thank you.
Okay. You can hear that okay, Ulrich?
Yeah. Thanks, Zolo. Thank you so much. Thanks.
Okay, very good. Abdullah, can you hear me okay?
Yes, I hear you now.
Yeah, any questions or comments for Ulrich?
In case of ICB high, in case of trauma, mannitol, how much a dose you give? If you give mannitol, and how many times?
We already had a very
well, can you answer it anyways, Ulrich? Go ahead.
Like we said, so in terms of mannitol right now, we are trying as much as possible to shift away from mannitol. It's more about hypertonic saline, if possible, right? So so Dr. Kabulo said we're going to try and have a session on the management of traumatic brain injuries and raised intracranial pressure. So as much as possible, if you can avoid mannitol and prefer hypertonic saline, then it's best. If you can avoid, then do it.
Okay, Dr. Kabulo. Dr. Kabulo, do you have any comments or questions for Ulrich?
Yes, Dr. Bennett, thank you so much. Ulrich, thank you for your presentation. So today it was a great day. You know, I came from my journey, I was tired, but you are now like feeding me again, so giving me more energy with this data. So it was great. It was great today. Nice presentation, Ulrick. Nice presentation, Zolo. So I have one question. You said when you are doing EEG, it's just to differentiate non-convulsive status epilepticus and convulsive status epilepticus. I don't know if I heard you well.
Well, first of all, thank you, Dr. Kabulo, and thanks for thanks for your comments. No, it's not just to differentiate. I was giving the primary indication. So the primary indications is trying to justify the fact that your patient looks well doesn't mean that he's not having convulsions. So that's one of the reasons why if you have these intracerebral EEG modalities, you should probably use it because you might not know what's happening in that brain. So it's not just to differentiate. There's a lot of things. There are a lot of reasons you can definitely use continuous EEG, and not just in a patient that has a coma.
Yeah, sure. That was my question. So that's why usually even in traumatic brain injury, every patient with severe traumatic brain injury, we do anti-seizure prophylaxis. Glasgow Coma Scale 8 and below, anti-seizure prophylaxis, because other patients, they present with subclinical seizures. So yeah, thank you so much.
No, thank you, Dr. Kabulo. Thanks.
Okay, very good. Thanks a lot for putting us all together, Ulrick, and we'll wrap it up for today.
Yes, thanks, John.
Great session. We're a little technically challenged at times, but we'll learn. We'll get better, and technology will inevitably improve with the Wi-Fi. So I think our future is pretty set if we stay the course. We just hang in there and we keep plugging. We'll be ahead before everyone else jumps on, because we will have trained during the hard time. So I appreciate you guys being patient, and thanks Abdullah for coming for the first time. Thanks Zolo for a great presentation. Another great presentation. I can't believe you guys are in medical school. Man, I was far behind where you're at. And thanks for the elder statesman, Dr. Kabulo, for overseeing things. So.
Thanks, John. Just remember, Dr. Abdullah, you have a reply to your question next week. We have a very good presentation by Zolo, because you asked about mannitol in traumatic brain injuries. Zolo will be doing a very great presentation, I trust, and we will have that question. We'll have the answers next week.
Yeah, and eventually when Abdullah becomes comfortable, if he wants to present, and you're setting the model, Ulrick, maybe we'll start a grand rounds from Libya too. You know, who knows? We're expanding the network slowly.
Yeah.
So I'm going to end this formally. We can stay here. Stay here. So thank you.
I hope that.